Good afternoon, judges, contestants, and friends. I will be presenting my study on the new mathematical model for the prediction of visual outcome in younger children with mechanical ocular trauma in comparison with the other models. As we all know that trauma is important cause of mechanical blindness, monocular blindness, and visual outcome is unpredictable because of comorbidity. The social impact is very much, and financial impact also is approximately 77 billion, 29% out of which is because of children. And these are the further challenges in the children, but most important challenge is the amblyopia, which has been overlooked in many studies. So there are existing predicting models. One is the ocular trauma score proposed by Kuhn et al. And CRT that is present, but nobody has validated this study with the larger prospective manner. So we tried to study this and published this in one in ophthalmology and another in JCRS in 2011 and 2012. And then we tried to look at the particular pediatric ocular trauma score, which is to be studied with particular important factors to be included in this study. And that is also discussed in LAJO, in ocular trauma study review article. So why the toddler ocular trauma score? In case of toddler 0 to 6, visual assessment on present may not be possible, which is the primary base for ocular trauma score or pediatric ocular trauma score. So Reed et al., which has published the article based on clinical finding, calculation of trauma score, but he has included 0 to 18 years and only in open globe injury. We tried to study these in all 0 to 6 toddlers and included open and closed both injuries. So this was the prospective cohort study with the ethical clearance, and we excluded all children who has not followed up for 6 years. The information is collected on a pre-tested online format using the ISOT form, and OTS categories were high risk to low risk, and pediatric ocular trauma score category from high risk to low risk were compared with the toddler ocular trauma score, which was 5 to 1. And ROC curve ROC curve was used to look at the sensitivity and specificity as comparing all three scores. To ease out the statistical analysis, we merged the high risk cases and low risk cases in two categories, and those are studied. Score calculation, as we know, according to Kuhn et al., this was the primary row score, and these are the condition, particularly globe rupture and ophthalmitis, perforating injuries, retinal detachment. They were deducted, but in pediatric cases, in pediatric ocular trauma score, we considered two more factors. One is the age. -10 was considered in amblyogenic age and wound location. The score calculation in toddler ocular trauma score was a wound size more than 6 mm, existence of hyphema, cataract and lens damage, choroidal detachment and detachment of retina. If sum was less than 1, it was good prognosis, and more than 1, it was poor prognosis. These are the result. 1630 total cases, out of these 681 were pediatric and 124 cases were the toddler less than 6 years of age. These are the age and sex distribution, and these are the 25% were the open globe and 75% almost was the closed globe patients. So mean age was 4.6. When we consider pre and post vision, different was significantly. When we studied the open and closed globe, we did not find any significant difference, and children less than 2 years had a significant poorer outcomes. So when we compared actual and predicted, we found these are the percentages in ocular trauma score and pediatric ocular trauma score, and these are the area under ROC curve which are documented. If we look at the high risk category, we could not find much of a significant success in TOTS, while if we consider the better group score 3, 2 and 1, we found the significant area which has covered, so which shows the high specificity and sensitivity. And we compared these parameters, and this parameter we find that with the high risk score, it was not effective. So this is the comparative summary of three models, and conclusion is toddler ocular trauma score is a novel predictive score which is more reliable than the POTS but less specific and sensitive in high-risk cases. This TOTS can be employed to examine the outcome in toddlers in whom vision checkup is not possible at presentation. Thank you.
Thank you, Dr. Mehul. Nice presentation. I think I can request the Trauma Society of India President, Dr. A.K. Grover sir, to comment.
So Dr. Mehul, this is a good study, something that has not been done for toddlers earlier. But would you again give us the relative benefits as compared to pediatric ocular trauma score that this particular score is providing?
When there is a ocular trauma, it is extremely difficult to measure the visual acuity in these children, particularly when it is 0 to 6. So it is better to detect them from the objective finding rather than subjective finding. That is the main purpose.
So what benefit has this given over the pediatric ocular trauma score?
There is a misjudgment of the visual acuity that might lead to the false prediction of the POTS. POTS also we have validated for 700 cases. So we have.
What was the age group used in POTS?
0 to 18.
Okay.
This was 0 to 6. This particular age group was targeted, which was not even done by Reid et al., who has designed this TOTS. He has designed for 0 to 18.
So eventually, what benefit do you think it will give us?
Basically, we look forward that objective finding, if we define the score, then it will be more reliable than the which is based on primary visual acuity.
Thank you.
Thank you, Dr. Mehul. Very nice. Thank you.